So the first one is kidney amyloidosis. When you are talking about any pathological condition, you should first give definition what amyloidosis is. So in this case, amyloidosis is a synthesis of abnormal protein. Amyloid is abnormal protein. And as you can see, this kidney is enlarged and it has yellow color, yellow or even white color. We can call it big fat spleen or big, not spleen, big fat kidney or big white kidney because it's diffusely infiltrated by amyloid. So amyloidosis is a synthesis of abnormal protein and accumulation in different organs and tissues. Amyloidosis can be primary and secondary. Primary amyloidosis is caused by malignant transformation of plasmacytes. Plasmacytes are cells which normally produce immunoglobulins, but when they are transformed into the tumor, they produce amyloid. Secondary amyloidosis can be observed in patients with chronic inflammatory conditions such as fibrocavernous tuberculosis, rheumatoid arthritis, bronchiectatic disease, etc. So different diseases, but you should name at least 2 or 3 examples when we can see this secondary amyloidosis. Spleen. Here you can see that spleen capsule of the spleen has white color, but if you will see the parenchyma, it's of usual color, brown, dark brown color. We can see this condition when, for example, near this spleen in the abdominal cavity there are some inflammatory diseases, and that is why this capsule changes and we can see hyalinosis. That is why it's quite dense, firm and white. Normally it's transparent, so not like this. Hyalinosis of the spleen. The one more condition, this is quite heavy, I will not lift. No, it's better not to touch this because it's quite dangerous. You can maybe zoom it. This is brown induration of the lung. And you should remember this specimen from the first semester. We had it on the topic disturbances of the blood flow. So this is condition which can be observed in patient with chronic heart insufficiency, and when you tell me that it can be absorbed, remember that this is left ventricular insufficiency, and we can see brown color of the parenchyma. And please don't be confused with these holes because these are just sectioned bronchi. It's nothing special, nothing pathologic. These circular structures are bronchi because we cut it, yes. The next one is stomach. Stomach with erosions. You can see mucosa. Mucosa is quite normal. I mean, we can't see any exophytic or endophytic lesions here, but you can see these spots of black color. And these spots are erosions. Why do we see this black color? Because when blood from erosions interacts with hydrochloric acid, so we can see accumulation of pigment, which is called hydrochloric hematine. Hematine is of black color, and usually erosions are healing quite well. I mean, when the patient is healthy, we don't see any marks of erosions in the future time. And I will show you, maybe now, not later, one more specimen, this one, because it's also stomach. And you can see mucosa, and you can see this big hole, yes? It's endophytic lesion, and this is ulcer. Ulcer, it's very important to differentiate between either erosion or ulcer. I will ask you, what is the difference between erosion and ulcer? So ulcer is a lesion deeper than muscularis mucosa. When muscularis mucosa is not involved, this is erosion, and erosion is characterized by this hydrochloric hematine. Ulcer is characterized by deep defect in the wall of the stomach. It can be quite deep. So we can see sometimes ulcer which affects the wall until muscularis propria or even tussirosa, and that is why there are different complications of ulcers, for example, bleeding, penetration, perforation, or what is healing. Even maybe 1-2 years later, we will see this defect because ulcer is healing with the scar formation. Erosion is healing without any scar formation. The next specimen is chronic cholecystitis, and you can see gallbladder, and the wall of the gallbladder is thickened because there is chronic inflammation in this patient. Besides, you can see in the hollow of the organ a lot of stones. So stones are some concrements which are situated in the lumen of the organ and which can be freely removed from this lumen. When there are some really firm accumulations of calcium, for example, in connective tissue in the body, these are not stones. Stones is only these bodies which can be removed from the organs. Or is steatosis of the liver. Or in Russian we use so-called гусиная печень name or goose liver, because you could hear about one food, foie gras, do you know? It's French. This is when the liver of the ducks or some birds, house birds, when they are feeding a lot, and that is why their liver becomes like this, and people eat then these livers. So in people it's quite similar. When a lot of fat accumulates in the liver, we call it steatosis. You can see that the liver is enlarged and it has yellow color, diffuse yellow color. Under the microscope, when you will see the slide, you will also have in your list this specimen steatosis. You should know that there are two kinds of steatosis, main kinds, macrovesicular and microvesicular. So macrovesicular means that these droplets in the cytoplasm are big, and the nucleus of the hepatocyte is pushed towards the border of the cell. When it's microvesicular steatosis, that means that droplets are really small. They are accumulated in macrophages in mitochondria, and the nucleus of hepatocyte stays in the center, not at the border somewhere, but at the center, and these small droplets just surround this nucleus. The next specimen is nutmeg liver. This is a little bit similar to the brown induration of the lung, because both conditions can be observed in patients with chronic heart insufficiency. But when the brown induration is observed in patients with left ventricular insufficiency, nutmeg liver can be observed in patients with right ventricular insufficiency. If the right ventricle doesn't push the blood into the small blood circulation, that means that all the venous blood accumulates in the big blood circle. And we can see increasing of the blood venous pressure in different organs of the big blood circulation, big blood circle. For example, in liver, the biggest pressure will be in the central vein. If you remember, the central vein is situated in the center of the liver lobule histologically, and erythrocytes also start going into the connective tissue. They're eaten by macrophages, and these macrophages have a brown color. On the periphery of the liver lobule near the portal tracts is the same as the color, because they have a lot of hemosiderophils there. And some areas have yellow color because there is steatosis. There are hepatocytes in hypoxia, they undergo steatosis, and we can see these interleaving zones. The next specimen is Echinococcus of the liver. Echinococcus is what? Who remembers? Echinococcus is parasite. Echinococcus multiracularis. So usually in Echinococcus, the patient has multiple cysts. So this is liver, and this is cyst, and we can see a lot of so-called daughter cysts or secondary cysts in one big primary. So firstly, we have primary cyst and a lot of secondary inside. And of course, parenchyma of the liver will be pressured under pressure. This is why we can see atrophy of this liver parenchyma, which surrounds this cyst in Echinococcus. The next slide, the next specimen is cysticercosis. So this is a disease when we see also multiple cysts, but in this time we can see a lot of multiple, not one cyst with a lot of secondary cysts inside like here, but just diffuse cyst in the parenchyma of the brain. And these are, how do we call it in English, don't remember the word, lichinki. So these are like early stages of development of this parasite, Taenia solium. So this is cysticercosis. And of course, in patients like this, usually they can have neurological symptoms. Excuse me. Scleroma. Scleroma is a productive inflammation which involves upper respiratory tract. And here you can see larynx, trachea, and main bronchi. And the mucosa of the trachea is infiltrated. And scleroma is caused by Klebsiella rhinoscleromatis. When you are talking about infectious or parasitic conditions, you should name etiological organism always. And you learned scleroma on our lesson, which was dedicated to productive inflammation, because scleroma is a specific disease. You should know 5 specific diseases: tuberculosis, scleroma, syphilis, lepra, and SEP. So these diseases are called specific because in these diseases we can see granulomas which have very specific structure. It means that we can't see granulomas of such building, of such type in any other diseases. For example, when I see granuloma in tuberculosis, I know that it's tuberculosis 100% without any additional tests. The same in scleroma. When I see diagnostic cells in scleroma in microscope, I know that this is scleroma. We will see this slide in our list of slides too. And when you are talking about scleroma, you should know the name of diagnostic cells. So in this disease, these cells are called Mikulicz cells. Mikulicz cells are macrophages with these bacteria in the cytoplasm. Klebsiella rhinoscleromatis, I mean. Macrophages with Klebsiella rhinoscleromatis are called Mikulicz cells. Look like big white cells with a lot of cytoplasm. The next specimen is so-called hairy heart or fibrinous pericarditis. So this is a disease usually in patients with also chronic inflammatory conditions, for example, which were complicated by secondary amyloidosis and chronic kidney insufficiency, and they have multiple fibrinous accumulations on their visceral pericardium. This is very bad condition because these fibrinous accumulations can be calcified, and in this condition patient very quickly develops kidney insufficiency and dies, because of course you can realize that normal heart movement is impossible when there are so many fibrinous accumulations in the pericardial cavity. The next one is primarily contracted kidney. You can see that this kidney is smaller than normal one, and it looks like shrinking, and the surface of this kidney looks granular. And you should know that this kidney can be an outcome of 2 diseases. First one is arterial hypertension, and second one is diabetes mellitus, because in both diseases we can see hyalinosis of the small blood vessels, and in the nephrons, it's very serious, because in hyalinosis of the small blood vessels, some glomeruli are atrophied, and some remained glomeruli undergo hypertrophy. And we see a contrast between atrophied glomeruli and glomeruli which are enlarged because they undergo hypertrophy, compensatory hypertrophy. This is why we can see that the surface of the kidney is granular, because somewhere we have nephrons, somewhere we have loss of nephrons. Why there is hyalinosis of the small blood vessels? They just are in hypoxia, because it's not enough arterial blood in the glomerulus when the lumen of this blood vessel is very narrow. So this is why they are atrophied somewhere. Okay. Questions? No? The next one is, I guess, hydronephrosis. So hydronephrosis, and this is a kidney, but of course it's difficult to guess that this is a kidney, because we almost don't see parenchyma, because in the hydronephrosis, parenchyma and cortex of the kidney are usually atrophied. And here you can see multiple cavities, because a lot of urine accumulates here. For example, due to some inborn conditions, some concrements, stones in this system, and parenchyma of the kidney is usually almost not seen. The next condition, I guess, this is stomach cancer. Here you can see stomach. Stomach has almost normal size in this case, and you can't see any endophytic or exophytic lesions here, but if you will see attentively, you will see that the wall of the stomach is very thick. Very thick. I showed you erosions and ulcers. You can see, for example, here, that this is very thin normally, and here you can see that it's maybe 1 centimeter or something, because the wall of the stomach here is infiltrated by cancer cells. And this is very special type of gastric adenocarcinoma, which we call signet ring type adenocarcinoma, because cells remind of signet rings. Signet rings is something like, I don't know, like this, signet ring type adenocarcinoma. They are non-cohesive. I mean that this cell doesn't build any glands, and this is very dangerous type of cancer. In this type of cancer, usually surgeons remove all stomach at the beginning, because it's spreading really fast. And when you are talking about cancer in every organ, you should know histological type, which we can see more frequently. I mean, when you, for example, when you tell me that this is stomach cancer, and I ask you what histological type of stomach cancer we can see, you should answer adenocarcinoma, because other types of epithelial tumors, malignant tumors, are squamous cell carcinoma and urothelial carcinoma. And it's important for you to know that we have cylindric epithelium there, and malignant tumor of the cylindric epithelium or malignant tumor of the glands is called adenocarcinoma. The next specimen is uterus with endometrial adenocarcinoma. Endometrium is also composed of glands. That is why when you see malignant tumors in the endometrium, this tumor is also adenocarcinoma. Here you can see cavity of the uterus and ovaries with fallopian tubes. In the center of the cavity, you can see exophytic tumor. Definition exophytic means that tumor grows into the cavity, not into the wall, deeply in the wall, but in the cavity of myometrium, and we can see this tumor as a polypoid substance. It can be removed by doctors, but when it's a malignant tumor, that is not, that doesn't solve the problem really frequently, because this is malignant tumor. That means that it grows into the wall also. Can come maybe closer. So this is aorta here, And on the left and on the right, from the aorta, you can see enlarged lymph nodes. And this is Hodgkin lymphoma, or another name of Hodgkin lymphoma, lymphogranulomatosis. So you should know that this is malignant also tumor, malignant tumor from lymphocytes and from B lymphocytes, because we have B and T lymphocytes. I guess you had lecture about lymphomas, and when you're talking about Hodgkin lymphoma, you should know that there are diagnostic cells. They called Rich-Denberg cells. There are other types of cells, for example, popcorn cells, which are Hodgkin cells, lacunar cells, but the main and the most important cells are Rich-Denberg cells. When I will make a video in Zoom for you, I will show them. I will show you these cells on the slide. But even when you're talking about gross specimen, you should know this name. The next time is spleen, also in Hodgkin lymphoma, and you can see that this spleen is enlarged, really enlarged, and because a lot of patients with lymphomas and leukosis, they have hepatosplenomegaly because all blood cells destroyed in the spleen. The next one is, I guess it's liver. Liver with metastasis of melanoma. Melanoma is a malignant tumor. Please don't make these mistakes. A lot of students, when they hear the ending oma, they think about benign tumors. But this is not the case in, yes, this is one of the exceptions. And melanoma, as well as lymphoma, is a malignant tumor of melanocytes. Do you know what melanocytes do in normal? They make melanin. They make melanin, and that is why we have different shadows of our skin. Those people who have more melanin, they have more darker skin. So in this tumor, melanin is also produced, and we can see that these spots with metastasis have black color. Sometimes we don't see any color in metastasis of melanoma because when the tumor is malignant, that means that the cells lose differentiation and they can stop producing melanin because they lose this function. But sometimes we see this pigment, and in your specimen it's present. The next one is also aorta, but this aorta is changed. It has a lot of pathological changes. This is atherosclerosis. And we discussed some steps or some stages of developing atherosclerotic plaques, and you should know that the first stage is fibrin strips and plaques, and the next one will be fibrotic plaque. The next one is atheromatotic plaque. The next one is atheromatotic ulcer, and the last one atherocalcinosis. So you should tell me all these steps of developing of atherosclerotic plaque. And atherosclerotic plaques can be complicated by ulceration when all the lipids just go onto the surface. Atherosclerotic plaque lose its surface, and in this in the result of this phenomenon, we can see formation of thrombi, because when the endothelium is broken, thrombi develop immediately. The next one is myocardium infarction. First of all, I will ask you about definition of infarction. Definition of infarction is really simple. It's ischemic necrosis. It's necrosis of the parenchyma due to ischemia. Very simple. Infarctions are divided by their color and by the shape. So myocardial infarction has white color, white with hemorrhagic corolla, so-called hemorrhagic corolla, because infarctions are white, red, and white with hemorrhagic corolla. And you should remember that this third special type is of myocardial infarction. And shape of this infarction is irregular because, for example, kidney has very symmetrical type of branching of the blood vessels. It's not the situation in the heart because we can see these coronary blood vessels which have branching in different directions, and that is why when we see infarction in this organ, it's of irregular shape, asymmetrical shape. If infarction was in kidney, it would look like maybe like this, triangular shape or something. But here we see just a lot of white spots and red corolla surrounding it. The next one is, okay, I guess it's aneurysm of the left ventricle. Aneurysm, you can see here. So you can see aneurysm. This is here. So this is like, I don't know how to say this word. Okay, this is not very stable. And in this aneurysm, you can also see a big thrombus which stabilizes it. Aneurysm of the heart, of the left ventricle, or of the right ventricle can be a complication of the myocardial infarction because in myocardial infarction, some part of myocardium is dead, and that means that this wall becomes really weak somewhere, and aneurysm can be developed. The next one is hypertrophy of the myocardium, and this is concentric hypertrophy because there are two types of hypertrophy, concentric and eccentric. Concentric means that this patient still has compensation of the heart function, and we can see that the thickness of the wall is enlarged. Normal thickness is up to 1 centimeter, and here we can see at least 1.5. And when this condition progresses, so we can see eccentric hypertrophy of the heart, it will be like this. Can you see the difference? So here it remains not triangular shape but circular shape, because it and the wall in eccentric hypertrophy myocardium becomes visually thinner because it has bigger volume. The main difference between concentric hypertrophy and eccentric hypertrophy is volume of the cavity of the ventricle. When the volume is the same as in normal heart, that means that we can compensation of the heart function. When it's enlarged, that means that heart can't compensate more this function, and the patient has progression of this condition. The hematoma in the brain, or you can also meet the name brown cysts. When this hematoma is atrophy? No, brown atrophy is about the liver. But here we can see in the initial stages, we would see just accumulation of the blood in the brain, but then when macrophages eat all these erythrocytes, we can see just cysts, and the wall of the cyst has a lot of hemosiderophages. Okay, the next one is, can you see what is this? Rheumatic endocarditis, and we can see acute varicose endocarditis because we have acute varicose and recurrent varicose. And varicose means that we see a lot of granulomas on the surface of this valve. Can you see? Something like nodules. It's really difficult to differentiate between acute varicose and chronic varicose, but you should just know these types of endocarditis in rheumatism in theory. The next, you should also know that the most frequent valve which is involved is mitral valve. Yeah. The next specimen is kidney in polyarteritis nodosa. Polyarteritis nodosa is a vasculitis which involves blood vessels of the medium size, medium diameter. So that means that aorta is not involved because aorta is huge. Small capillaries will be not involved because they are very small. But arteries of the parenchymatous organs, of the extremities, will be involved. And in polyarteritis nodosa, we can see very intermittent picture. I mean that somewhere we can see bleeding because we can see fibronode necrosis of the vascular wall, and somewhere we can see organization of this process. And when the process is organized, the lumen of the blood vessel can be completely closed. And in this situation, we will see infarctions, because infarction is ischemic necrosis of the kidney due to obstruction of the blood vessel. You can see both changes, bleeding and infarctions. You should read a little bit more theory about this disease to understand why we see these two types of change, because it's difficult to explain quickly, but I think when you will read, you will understand easily. Okay, the next one, I guess it's fibrinous pleuritis, and also we'll see a lot of zones of infiltration here. I should check what is it, but I guess that this is pneumonia, focal pneumonia. I guess so. I will check. What is this? So now this is tuberculosis. So yes, this is focal pneumonia, and you can see a lot of zones which can involve upper lobe, lower lobe, and it goes with the branching of the bronchi. So the bronchi are branching in different directions, and all these foci of pneumonia go accordingly to this bronchi. You should know the differences of focal pneumonia or bronchopneumonia from lobar pneumonia. And you can see in the next specimen lobar pneumonia, which involves the whole lobe. And we can see very definite steps in development of lobar pneumonia. The first step will be infiltration. The next step will be a so-called red hepatization, because a lot of erythrocytes will be in alveoli. On the next step, it will be yellow hepatization, and here we can see yellow hepatization when neutrophils come into the alveoli and eat all the erythrocytes. And the last step will be healing, or just how to recovery of the patient when all this exudate just disappears. And both of these specimens you learned on the topic acute inflammation. Acute inflammation can be ulcerative, exudative, and proliferative. No, acute inflammation will be ulcerative or exudative, and we have proliferative inflammation, which is already chronic. And exudative inflammation is divided by the type of exudate which is produced. And for example, here we can see suppurative type of exudate, and here there is fibrinose type of exudate. And also you should know that there are two types of fibrinose inflammation. They are Krupus and diphtheric. And this is Krupus or lobar pneumonia, and that means that this is Krupus inflammation. Okay, what is this? Okay.
Chronic obstructive pulmonary emphysema.
Oh, really? Okay. I thought first that this is polycystic kidney, but okay. Emphysema, not really looks like lung at first look, but you should just remember so. You can see that it has very cystic organization, because emphysema means that interalveolar the tissue is destroyed. That is why we can see a lot of small cavities in the lung. Of course, this is bad because there is no any metabolism in these tissues, because all the interalveolar spaces has only air without any tissue. The next one I showed you, this is ulcer of the stomach. This one is appendicitis, phlegmonous appendicitis. It's also an example of the exudative acute inflammation. And here we can see that appendix is enlarged. It's red. And when do we call it inflammation in the appendix phlegmonous? When we look at microscope and we see neutrophils which are infiltrating all the layers of the wall, starting from mucosa to serosa, that means that this is phlegmonous inflammation. When we see, for example, a defect of the wall until muscularis propria, deeper than muscularis mucosa, we call it ulcerative appendicitis. When we see inflammation just in mucosa, not involving serosa, not involving any other layers, we call it surface appendicitis or catarrhal appendicitis. So types of appendicitis are divided because of different types of lesions, different spreading of this disease. Here is liver cirrhosis. Liver cirrhosis. First, definition of cirrhosis. Cirrhosis is a transformation of normal liver architecture into abnormal lobules. So abnormal nodules, or we can call it also regenerative nodules. That means that islands of hepatocytes are surrounded by fibrotic tissue. Firstly, we have fibrosis in the liver, and cirrhosis is an end stage of fibrosis in the liver. This is quite serious for the patient, because in patients like this one, there are a lot of possible complications, such as hepatocellular carcinoma, for example, bleedings from the varices in the esophagus, because they portocaval and cava-caval anastomosis are open. And of course, when the patient has liver insufficiency, there is no production of different important substances, for example, anticoagulative factors, and we can see, or coagulative factors, we can see bleedings or thrombosis in the patient. Cirrhosis can be divided due to size of the nodules as macronodular or micronodular. Macronodular cirrhosis means that these nodules are more than 3 millimeters in diameter. Micronodular means that these nodules are less than 3 millimeters in diameter. The next one is also cirrhosis, but this micronodular, because you can see even here that this liver has granular surface, and it's almost not seen that this liver has a lot of nodules. This liver has greenish or yellowish color because this patient has jaundice. The next specimen, this is esophagus, and you can see varices in esophagus. What varices are? Varices are dilated veins because, as I told, in patients with, for example, cirrhosis, portocaval and cava-caval anastomosis are opened. And that means that in normal people we can't see any veins on the mucosa of the esophagus, but in patients with chronic alcoholism and cirrhosis, for example, we can see these dilated veins. That means that during traumatization by food, for example, or something else, chemical factors, these veins can be injured, and this patient can develop severe bleeding. And sometimes their cause of death is white blood loss, of these patients. The next one is acute kidney insufficiency. You can see that this kidney probably is a kidney of a child because it's quite small, and you can see a very good contrast between cortex and pyramids and medulla, yes, because cortex undergoes ischemia, and we can see white color in the cortex, and medulla is full of blood because here we can see necrosis of the tubules, and also one component of the shock is centralization of the blood. That means that it will be concentrated in the central parts of the kidney. But the main thing you should recognize here this contrast between white and red color in parenchyma of the kidney, which will tell you that there is abnormal distribution of the blood in the kidney.
You told this.
Okay, the next one is acute pyelonephritis. Acute pyelonephritis is acute inflammation of the urinary tract and infection of the kidney of the urinary tract. Pay attention that glomeruli are not affected, because if it is inflammation of glomeruli, we will call it glomerulonephritis. And here we see only involvement of urinary tract tubules in cortex. That is why it will be more correct if you will say acute, because pus exudate is a characteristic of acute inflammation. That is why it's not really correct here. I think so. Besides, if it is chronic pyelonephritis, we will see secondary contracted kidney. I mean that it will be small, shrinked. We will see a lot of scars on the surface. But here you just see that the kidney is enlarged. You can see edema and a lot of these small nodules, which contain a lot of pus. Under microscope, pus consists of neutrophils, and these are small microabscesses in the cortex. Infection can come to the kidney by two main ways. First one is ascendant way. Ascendant means from bacteria of our genital tract, for example, and it goes to the kidney by ureter, for example. If the person has some severe infections in the blood, for example, septic apiemia, infection can be hematogenic, and bacteria can come here by hematogenous way also. The next one is, okay, this is a big red kidney, so-called big red kidney, in rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis has different synonyms. Also, you can meet such names as glomerulonephritis with crescent formation. Crescent, you know what is this? What is this?
Crescent?
Crescent. Crescent is a shape. In this slide, you also have such specimen. You should see crescent-shaped fibrin accumulations in the capsule of glomerulus. And macroscopically, kidney looks enlarged, and on the surface of the kidney you can see, maybe here it's not really good seen, but usually a lot of small red dots. Small red dots. Yeah. Moon-like is the same. But moon is full circle and crescent.
No,
yeah.
Moon.
Yes.
Where can I see crescent shape?
Crescent means like not full moon,
Yeah,
but
where can I see it?
not here in microscope. But this is just synonym you should know. Also, we can call it acute, rapidly progressive. And what else I should say? In this condition, patients develop hematuria. We can see erythrocytes in the microscope, in the urine of this patient, or even grossly, when the patient goes, for example, to the bathroom and he can see blood in urine by his eyes also, not only in microscope. The next one is brain in meningitis. Meningococcal infection can manifestate by different ways. First one is meningococcal nasopharyngitis. It's, I think, more simple and not very dangerous form of meningococcal infection. The second one is meningitis.
It's bacterial infection, right?
Yes, bacterial. And Neisseria meningitidis is etiological bacteria of this process. And here we can see involvement of the brain surface of the brain. And yeah, exactly. And if we saw here also involvement of the brain substance, we would call it meningoencephalitis, for example, or just encephalitis. Sometimes the situation is even more severe when the patient has generalized infection of the whole body, and we can call it meningococcemia. These situations are characterized by diffuse rash on the body, and these spots are not removed by pressing on them. So this is very severe complication, which is characterized by development of disseminated intravascular coagulation sometimes. The next specimen is, so this is bleeding in adrenal gland, and here you can see small kidney. Here you can see small kidney and a lot of blood in the adrenal gland. This syndrome has its name, Waterhouse-Friderichsen syndrome. It's difficult, but a lot of teachers ask it on the credit, on exam. Waterhouse-Friderichsen. Difficult, but still. Usually this complication is very severe because, as you can remember, medulla secretes adrenaline, noradrenaline, which regulates our blood tonus, blood vessels tonus, and when we can see such a lot of blood here, usually this function is lost. That is why these patients develop shock and die. Yes.
Where can you find the hemorrhagic nephropathy?
Colon in Escherichia coli infection. So Escherichia coli infection is characterized by development of pneumatosis in the colon. That means that a lot of air concentrates in the wall, and you can see it like bubbles on the surface. Besides, you can see hemorrhagic spots, somewhere catarrhal inflammation, and so contrast between catarrhal inflammation, hemorrhagic spots, erosions, and this accumulation of air. The next one is colon in dysentery. Dysentery or shigellosis. Maybe shigellosis is better because you can remember that, yes, it's caused by Shigella dysentery. It's important to remember that in shigellosis we see fibrinous inflammation of the colon, and that means that on the surface of the colon there are a lot of accumulation of fibrin. I told you that there are two types of fibrinous inflammation, lupus here in lobar pneumonia and fibrinose here in shigellosis.
Colon.
In colon, yeah. Mm-hmm.
Can we just say...
The next one is eccentric hypertrophy of myocardium, and I guess, what is it in your list?
Septic endocarditis.
Okay, also septic endocarditis. So we can see also involvement of the valves. And you can see that on the surface of the valves there are vegetations. Vegetations are accumulation of thrombotic masses, of bacteria, and
septic endocarditis.
So they are quite big, and of course normal blood function is lost here in this patient, and he has eccentric hypertrophy of the myocardium. Okay.
Catheter sepsis.
We can see also this heart is very small, and you can see this catheter here. Can you see?
Mm-hmm. Yes.
Small tube. Small, like
got it.
tube. This one.
Sure.
Yes.
Okay. It's very small. So this is catheter. Yeah. And catheter in the atrium. And on the valve, you also can see this accumulation vegetation. Can you see? This small polyp. Looks like polypus vegetation.
Yes,
Better. Is it thromboendocarditis?
Thromboendocarditis.
पूरा
Yes.
नाम है उसका वास्तव इसका मतलब
The next one is tuberculosis. So, tuberculosis is it primary with progression. Primary tuberculosis complex. So we discussed tuberculosis a few lessons ago, and you should know that primary tuberculosis complex consists of three elements. First one is primary focus or primary effect. Here we can see a lot of primary effects actually, because I mean a lot of areas of white color with caseous necrosis, because this primary effect grew. And also in the regional lymph nodes, you can see it here, You can see also these white spots because second component of primary tuberculosis complex is lymphadenitis. And also the third one is lymphangitis. Lymphangitis is inflammation of the lymph vessel. Yeah. There are different also, concerning this specimen, there are some types of progression of primary tuberculosis complex, for example, hematogenous, lymphogenic dissemination, and growth of primary tuberculosis complex. And here we can see growth, because we don't see only one focus. Also, I can ask the outcome of primary tuberculosis complex. This focus is called gone focus. Gone focus. Yeah, when it heals, it's gone focus. Okay, maybe we should sit down. Okay, the next one is one in miliary tuberculosis, and you can see that the whole lung is infiltrated by these small nodules of white color because they contain caseous necrosis, and they are very multiple, and they are just a few millimeters in diameter. That is why we call them miliary. You should always know how tuberculosis granuloma is organized. You should tell me that in the center of tuberculosis granuloma we see caseous necrosis, at the periphery we see lymphocytes, epithelioid cells, and giant cells or multinucleated cells of Pirogov Langhans. In English literature you can see almost always the name Langhans cells. Langhans cells. Yeah. Not Langerhans, Langhans. Langhans cells. Okay, the next specimen, what is it? Kidney with tuberculosis, no? Or polycystic disease?
Polycystic disease.
Polycystic.
Tuberculosis.
Tuberculosis, okay, polycystic later. It looks similar a little bit. So, here you can see enlarged kidney and multiple cavities. So this is fibrocavernose, I guess tuberculosis, because there is also secondary type of tuberculosis which can involve not only lungs as any other tuberculosis, but also in other organs. And you can see a lot of cavities. Some of them are empty, some of them are full with necrotic masses, but still it can lead to, of course, chronic kidney insufficiency and amyloidosis in such patients. The next one is polycystic kidney disease, and you can see that this kidney is gutted and opened, and you can see that it consists of multiple cysts, because this is inherited condition when the patient has cystic transformation of the collecting system of the kidney, and we can see a lot of these elements here. The next one is multiple defects, congenital defects in born, and you can see anencephaly here, and you can see that these inner organs are on the abdominal wall. So these are multiple congenital defects, and extremities are decreased in size, also defects of the face development. So you should review these congenital defects and name something you see here. And the next one is our actually today's topic. This is toxoplasmosis. Toxoplasmosis of the brain. You should tell me that this disease is caused by Toxoplasma gondii. The person, I mean the baby, can be contaminated in transplacental way, and you should tell me four main characteristics of this condition. The first one is microcephaly, that means that brain is reduced in size. The second one is cyst development. You can see that ventricles of the brain are transformed into cysts because they should not be that big. And in the walls of the cyst you can see calcium deposits. And other important clinical symptoms are chorioretinitis. This is inflammation of retina in the eyes, and chorea. Also cramps. Cramps is a clinical symptom, of course. Pathologists don't see this, and I guess it's enough. Yeah. Also, toxoplasmosis can be different in dependence of how early it's developed in the child. For example, until 28 week of pregnancy, when the child is just starting development of central nervous system, it can be really severe. We can see microcephaly, poorcephaly, pseudoanencephaly, and others, disruptions in the brain. If the baby is almost developed, we can see easier forms, for example, meningitis, which caused by toxoplasma, and some troubles with parenchymatous organs. The next one is hydatiform mole, a little bit interesting name. So this is a transformation of chorionic villi into cysts, and these cysts don't contain any vessels. This mass is usually present in the cavity of uterus here. It can grow into the wall of the uterus. In this case, we call it invasive hydatiform mole, and sometimes it can be spread in hematogenous way all over the body. And in this condition, if these small particles are becoming malignant tumor, this malignant tumor is called choriocarcinoma because it's developed from choriocarcinoma. Next one is multiple fibromas or leiomyomas in the uterus. Leiomyomatosis is the same. And you can see a lot of nodules. These nodules are benign tumors, leiomyomas. Leiomyoma is a benign tumor of small muscle. These tumors are not really dangerous for the woman. They can transform into malignant tumor, very rare, and most of the time they give other problems. I mean, for example, this woman can't become pregnant, or it brings a lot of pain to her. So sometimes they are removed surgically, but not because they become malignant tumors, just because they cause a lot of problems in the patient. But if they are single tumors, so almost everything, it's not a problem for women at all. What is this? Okay. Here you can see that lungs are small and they have numerous red spots. Very often in asphyxia, highly membranes are developed in the lung because in hypoxia, fibrin starts to go into the surface of alveoli, and that is why you can see a lot of these hemorrhagic spots also. The next one is hemolytic disease of the newborn. This patient also has jaundice because you can see yellowish shadow of these organs. And what organs is increased? Can you see?
Yes, liver.
Liver and spleen. So this child has hepatosplenomegaly, and you should know the cause of this disease. This disease is developed due to conflict between RH, the system of mother and fetus. When the fetus is RH plus and the mother is RH minus, so they have conflict. But antibodies of the mother go into the blood system of fetus and destroy erythrocytes of the fetus.
In this condition, the child will be dead.
Yeah. He will develop hemolysis, massive hemolysis. That is why hepatosplenomegaly is present. And besides, you will have such slides in your list of microslides. We can see multiple extramedullary hematopoiesis, and it will look like erythroblasts, myeloblasts, different cells of blood which are situated in different areas of the body because of this massive hemolysis. There are 4 main types of hemolytic disease of the newborn. They are maceration. I don't know if it's the same definition in your test, but maceration is when this fetus is born dead and calcifies even sometimes. So the next one is edematous form, when the main symptom is edema. The next one is jaundice form, when the main symptom is jaundice, and hemorrhagic form, I guess, when there is bleeding. The next one is cephalohematoma or cephalohematoma. So here you can see bone, and you can see bleeding.
Hemorrhage.
I don't remember the word in English, unfortunately, not kosinitsa. So this is no. in Ukrainian.
Hemoptosis.
1 moment, I will check. This can be during the Partus procedure, and this is trauma of the fetus, of course. It's sometimes it takes time for blood to accumulate in the periosteum, but it can press on the brain, and sometimes child can die because of this. The next one is almost the last. This is Wilms tumor or nephroblastoma, and you can see small kidney. Can you see?
Mm-hmm.
And this